also, if you perform microsuction, it can sometimes pose a risk in terms of exacerbating the patient's tinnitus. And therefore, if possible, the ideal method of removing this earwax is via mechanical instruments. So Curette, which we're using now, earhooks and forceps. And so the specialist, my colleague who this patient with saw, mainly performs microsuction. So they recommended that they can visit me to see if I can help. It was quite a challenging case, also because the patient's ear canal was quite narrow and some of the wax was quite deep. It wasn't up towards the eardrum, thankfully. If it was, it'd be really, really difficult to remove this without performing microsuction. And also the consistency is it wasn't wet, but I would say it's quite loose and soft. If this was a bit firmer, you could get a Johnson warning or even forceps and trying to pull it out in one singular lump. But here we're having to remove it in little sections and parts because it's so loose. Now I'm alternating between a plastic, carbon fibre, nylon filled carbon fibre, should I say, Johnson horn, and also the metal one. And the reason for that is in this varieties, some of this wax is a bit deeper, and the metal stainless steel, so surgical stainless steel one, is a bit longer, so I've got better reach. So I felt a bit more comfortable using that to remove some of the more deeper wax. However, the metal version, of course, it's got a greater strength. If it does come in contact with the bony part of the ear canal, it can be a bit more uncomfortable. So you have to weigh out the pros and cons, the benefits, and the disadvantages of which one to use and when to use it. So if anyone is new to my channel, I'll just give you a quick overview of the ear anatomy and physiology. So our ear canal is approximately 2.6 centimetres in length, and it's best to divide the ear canal in thirds. So the outer third is made up of cartilage. So cartilage is semi-rigid, it's malleable, and sitting on the cartilage portion of the ear canal is a thick layer of skin. It's about 1 millimetre in thickness. And the inner 2/3 of the ear canal, however, is made up of bones. The bones are a lot more sensitive and it's rigid, it's not flexible. And in addition, the skin that lines the bony part of the ear canal is far, far thinner. It's less than 0.1 millimetre in thickness, so 10 times thinner. And that sits direct on the bone, making the bony part of the ear canal, the inner 2/3, extremely sensitive. So whereas we could apply some pressure on the cartilage portion, just as I'm doing here, we wouldn't be able to do that on the bony part of the ear. It would be very uncomfortable. So we've made good headway here. So the patient could instantly hear better at this point, because as you can see, the eardrum's pretty visible and sound waves to travel through. But we're just trying to see if we can get as much out as possible without risking the trauma. So again, I've gone towards the metal Johnson horn, so little ear Curette. It's got different names, ear scoop, Curette, Johnson horn. Interestingly, I'm developing my own version. I'm really excited by it actually. We've spent a lot of time designing it, and it's got quite a few unique features, the Johnson horn. I won't say too much at the moment. It should be ready in the next couple of months, so we're in the production process. I think it would really help in this case, particularly in the left ear, so do stay tuned with the left ear. What I've done there, I've just brought some of this deeper wax forwards, and then I reverted back to the plastic one. The plastic one, if you do make contact with the bony part of the ear canal, again, I'm not saying it's not more comfortable for the patient, but it's going to be more tolerable than the metal one. So using them in conjunction with one another. And this is now on the cartilage portion. You can see all this hair. So these hairs should only be found on the outer third of the ear canal. I can start to apply a bit of pressure to really scoop out. This is just past the first bend, before the second bend, so just about less than a centimetre into the ear. And this patient's got a little trench gone in and out, scooping this piece out. I wasn't able to take a still image at the end of all the wax. It was just a really busy clinic, so the next patient was waiting. So these procedures take a bit longer. Suction would have been a lot quicker, but of course, I wanted to avoid that. The patient specifically, they came to me to try and avoid using them. Fortunately, no. So again, just use the metal. If you want to bring some of this deeper wax forwards, and once it's more in the safe zone, the cartilage zone, we'll just revert it back to carbon filled nylon. With this as well, it's a bit broader, the plastic one, gives more coverage, so I'm able to remove more wax in a seamless scoop with the plastic as opposed to the metal. Quite a few hairs just at the entrance. This is one bit, we could have left that from this, but I thought that patient was so still, so we did actually manage to remove that piece of back from the posterior back part of the earcanal wall. I'm just mopping up the entrance first. The eardrum, you can see it's intact, slightly retracted, the eardrum looks a bit buckled inwards superiorly. So we may have a bit of research. In fact, we did have a bit of gestation dysfunction when the cells were correct. So again, I've just used the metal to bring that forwards. It's more in the safe zone now. It's probably still on the border of the bony part cartilage, but because it's closer, I'll be able to reach it with the plastic version. So yeah, I'm not going to go for any more because that would involve scraping the wall. A bit of wax is good for us. If I do go for any more, it's more naturally near the entrance, but yeah, I'm really pleased with that. This is the patient's left ear. There's a little gap in the middle. The left side, I found the wax to be a bit drier. It wasn't dry enough, however, to use forceps. The forceps just cut through it, or an ear hook, so it just dissects. I still had to continue with the jobs and horn. The wax is a bit more embedded up against the back part of the earcanal, particularly the base of the earcanal. It's not as loose, a bit more sticky. Now when the patient attended, I actually performed the left ear first, but I'll show you the right ones. I just felt it was probably a bit more exciting on this side. So, trying to get underneath this side. Now the view can change somewhat between the right and left ears, and the reason for that is if you're right-handed, like I am, I'm holding the instrument in my dominant right hand and the eye clear scope. So anyone who doesn't know how the procedure is performed and what it looks like externally, I uploaded a video a couple of days ago where I performed the procedure live on TV. The reason I make a reference to that is it's great, you can actually see the way I'm holding, how it's all held, and the technique. Give you a bit more perspective on how the procedure is performed. So with the right side, because I'm using my right hand to go into the ear and the angles, I'm using the endoscope to gain access into the ear. I'm putting the endoscope inside the ear, and just past the entrance, once I'm there with the endoscope, I'm pushing it to the left to almost open the ear canal, because our ear canals are not straight, they're bendy and twisty. Because the endoscope has to go into the ear to stretch the ear canal, it means that initially any wax that's close to the entrance is quite zoomed in, because that's purely because we have to put the endoscope in there to stretch the ear. With the left side, it's sometimes a bit different. We can actually position the endoscope out of the ear when it's got more lateral wax, and use the instrument to stretch the ear open to gain access. So, when I first started performing endoscopic ear wax removal, I used to prefer the right ear, because the left ear, the technique, especially if the wax is deeper in the ear, because your hands can quite easily cross over in the left side, and it used to probably for me a bit as well when I first started, until I developed a technique where I can stretch the left ear using the endoscope and then going with the instrument. But I used to always prefer the right ear. Now it's the complete opposite. I always prefer the left ear. It's a bit odd why. So yeah, I think most right-handed people performing scopic ear. I do prefer the right ear from our training courses. I'm kind of going the other way now. So, the majority of the ear canal's clear. Now, I didn't have to use the metal one here because it's just about able to reach. It's really sticky, and I'm just going to be careful because we are on the bony part. Now, some of you may wonder why Jobson Horn's got a hole in the middle that's hollow, and you can see probably why here at the moment, and you'll get a better idea near the end of the video. Without that hollow section in the middle, what would happen with soft wax is as you're scooping it out, you're going to spread it like butter against the canal wall, so you're not really going to remove it. So when you've got a hollow centre, soft wax, as you're kind of scooping the wax away off the canal wall, soft wax travels up the hollow section, and you get like a little spiral effect at the top. Just like that, you can see. Without that hollow section, it looks like a potato peeler in a way. You get the skin of the potato going through that hollow part of the blade. And if we didn't have that, it would just spread it against the canal wall, making it more difficult to remove. So again, I can just about reach this with the plastic blade. Should ask the back. But as I'm kind of gently scooping it is really impacting against the canal wall, so it's a lot more stubborn in comparison to the left side where you're gliding it and the loose wax is coming away easily. But again, already at this point we've got a really good view of the eardrum. The patient can hear really, really well. But just wanted to get as much out as possible. So, spoiler alert, there is a bit of wax left behind. Please don't hate me for that. I decided not to continue more because I don't feel it's necessary, and also I'm going to put the patient in there. They've come here to help them hear better, not for me to induce any discomfort and pain. So I felt it was just the right time to stop, and I did on the left side. Just trying to go into the cartilage portion here, just put a bit more pressure to give it room. Again, you can see the benefit of that hollow centre. The wax is going up it. A bit of the difficulty in this ear was knowing how thick this layer of wax was as well. Especially on the bony part, you don't want to embed the Jobson horn too much, just in case it's a very thin layer. And then you're literally grazing the canal wall, the bony part, the skin, you're going to damage it, going to cause micro abrasions, and you can potentially bruise and cut the ear. So it's just judging, I can see a bit of the canal wall there, just to the right, so it allows me more insight of how thick this layer is. So we do some cartilage portion again here, so I can just apply a bit more pressure. It's in between each scoop, we're trying to just clear all this wax, we just put it in between a tissue, and squeeze out all the wax and then wipe it. Do get a bit more out. As I'm bringing the Jobson down, also just curving the end of the Jobson horn to resemble the curvature of the ear. And this is a good illustration. With this Jobson horn here, the standard Jobson horn, it's got a flat edge. So you can see there, there's a little curve there because it's round. And one of the things that, without saying too much, is that with the Curette developed, I've taken that into account. So I mentioned when I was doing the right ear, then the Curette that developed would be quite suitable, especially for this ear, especially when you're trying to remove the wax directly off the ear canal. At the bottom of the ear in particular, at the top, because that's where the curvature is most pronounced. But when you've got a flat edge to something like this, it's a bit more tricky because you don't want to graze the edge against the side of the canal wall. to avoid the metal one in this end, I think this was just a bit more sensitive for the patient. Persevere. It would have been great if this was a bit longer than that. I think I'm just slightly struggling to reach the end of the wax. That's about 2/3 the way in. Just inverted the hole. Just working the coverage portion between this. So it can be quite a tedious procedure. With microsection, we've probably got a bit of oil in there. What the oil would have done is bind the wax together and loosen it a bit. So I managed to get a bit more of a deep reach there. You can see that quite a bit deeper. Slowly going, just hovering over it. I don't want to scratch the ear at all. But yeah, with microsection, we'll probably just put some oil in there, coagulate it on the wax, and we'll do quite a quick procedure, I thought. But again, definitely introducing noise when possible for this particular patient. Nearly there now. And again, there is going to be some residual wax going through there. I'm not concerned about that. Bit of wax is good for you. So wax is slightly acidic, and the acidity helps to inhibit harmful bacterial and fungal growth. It also helps to serve as a natural insect repellent.